know?
Well, doctor, your first patient is a 55-year-old man, and he's come to see you because he had this god-awful halitosis. His wife told him something must be wrong, and she said, "You've had all this trouble eating. You ought to really see the doctor." He ended up seeing a gastroenterologist who found that he had achalasia. And he had a GI study done in the doctor's office, and he brought it with him, and he's come to see you because the gastroenterologist said, "You better see a surgeon. This is something that he might be able to help you with." How are you going to manage this patient?
I would first start by doing it, like to know how long the patient's had these symptoms for.
Doctor, I've told you everything you need to know.
Okay.
He's referred for the surgery. How are you going to manage him going forward?
Okay, then I would like to start by examining the patient.
Okay, his exam isn't helpful. It doesn't show you anything that's going to make a difference. So now, what are you going to do in your management of this patient?
Well, I would like to get a esophageal manometry to confirm if this is truly an achalasia.
Well, what is it you'd be looking for on manometry, doctor?
I would look for the lower esophageal sphincter is very high, and there's a peristalsis in the segment above that.
So you send him off for a manometry study, and he brings it back, and they saw a very poor peristalsis in the esophagus, and the lower esophageal sphincter pressure was upper limits of normal. What are you going to do now, doctor?
I would like to, the patient had a barium swallow.
Yeah, he brought the films with him.
And the patient, I would like to see if the patient's had an EGD.
No, he hasn't. Would you do that?
Yeah, yes. But I don't, yeah, okay.
Yes.
Yes, I would.
Yes. And I don't care if I do EGDs and the GI guys won't refer to me. No, okay. You don't take that route. Okay. EGD, the scopes, you see a pretty good esophagus. He had just liquids the 2 days before. It looked like it was narrow. The scope slipped right in.
So just to summarize, the patient has an X-ray which appears to be, which has a stricture, but the esophageal manometry is questionable, but the EGD did pass through. So this is not it's not a stricture, therefore, because the EGD did pass through. I would recommend the patient have a hilar myotomy.
Okay, what approach do you use for your hilar myotomy, doctor?
I would do an abdominal approach. I would do a midline incision. I would mobilize the short gastric from the splenic artery, and I would mobilize the gastrohepatic ligament and identify where the right and left cruce are, and I would dissect the esophagus posteriorly. I would pay attention to the vagus nerve on the left posteriorly, right anteriorly, and free up the esophagus and try to mobilize this downward.
Okay, doctor, and you do your myotomy. About how far up on the esophagus and down on the stomach do you go?
I would do 4 centimeters on the esophagus. I would go, and then 2 centimeters on the stomach.
Let's just say that things didn't go well and you got into the mucosa. What would you do?
I would then, well, the patient will get a Nissen fundoplication as well. So that's how I would do the Nissen. Well, I take that back. I apologize. I would first repair the.
What sutures would you use?
I would use 2-layer vicral sutures, and repair the defect, and then I would like to see if I can get omentum to patch the area as a buttress, and then patient would get a fundoplication.
Fine, doctor. I think Dr. Hardy has some questions for you.
So you go back to your office, and there is a woman there who is about 68 with her daughter, and the daughter tells you that her mother really is a little confused in the last 3-4 months. Hasn't been really quite herself. She has her memories all right and so forth, but she's depressed, and her personality seems to have changed a little bit. And as you take the history, you find that she also has a history of having passed renal stones several times in the last 10 years. And otherwise, she has actually been quite well. What would you do at this point?
This sounds like she has symptomatic hypercalcemia.
What would you do now, doctor?
I would first examine the patient, checking for any nodules in her thyroid.
So you check her, and in fact, she has a slightly enlarged thyroid without nodularities. You do not feel any nodules in the neck. And the rest of her exam is pretty good, although she seems to have really somewhat depressed reflexes.
This sounds consistent with hypercalcemia. I would send off a calcium and
so her calcium comes back 12.
This is elevated. I would then check a 24-hour urine calcium to make sure this couldn't be familial hypocalciuric hypocalcemia.
It's okay.
If that's negative, then I would get a PTH level.
And her PTH is 120.
So this is elevated. Patient has hyperparathyroidism. I would then see if a sestamibi scan. I would like to get a sestamibi scan.
Sestamibi scan shows a very accentuated 2-centimeter nodule in the right lower pole of the thyroid gland.
Okay. The patient appears to have an adenoma, which is causing hyperparathyroidism, and will need a parathyroidectomy. But prior to that, I would treat her hypercalcemia by admitting and giving her IV fluid to help bring that down, and loop diuretics also to.